So hi everyone, welcome to Quick Care Bites, a collaborative effort between SICM and Med for Medicine. My name is Jem and I'm an intensive care trainee and I'll be your host today. Quick Care Bites is a video podcast series where we interview experts in the field to distill clinical pearls and wisdom around critical care topics. Today, for our inaugural session, we are very privileged to have Dr. Jason Phua, a respiratory physician and intensivist at the National University Hospital and Alexandra Hospital, to talk to us about acute respiratory distress syndrome, otherwise known as ARDS. Besides being an outstanding clinician and excellent educator, Dr. Jason is also the CEO of Alexandra Hospital and is an also accomplished researcher where he holds key positions at the National Intensive Care Unit Repository, NICOR, and the Asian Critical Care Clinical Trials Group. Thank you for being with us today, Dr. Jason.
Hey, thanks, Simon. Thank you.
Yeah. So for the first of our 4 interviews today, we'll begin with the topic on the diagnosis and evaluation in ARDS. So Dr. Jason, perhaps just to start us off with the basics, what is ARDS and why is this an important condition?
So ARDS is acute respiratory distress syndrome. We have learned a lot about it over the last few decades. It was first described way back 1967. And initially, it was called adult respiratory distress syndrome. It's now known to be present also in kids, right? So it's acute respiratory distress syndrome. And to put things quite simply, it's a condition in which there is quite a lot of diffuse inflammation as well as edema in the lungs. And this is because of triggers, insults to the lungs that we can talk about later on. But essentially, this insults to the lung affect the endothelial as well as the epithelial barriers of the lungs. And as such, there is leak of proteinaceous fluid into the alveolar spaces. And because of that, number one, there is loss of lung compliance, there's increased ventilation perfusion mismatch, there's shunting, and then you get hypoxemia. But in addition to that, because of the endothelial activation, there are also problems of microthrombosis in the capillaries of the lungs. And as a result, you get dead space, and then you can get hypercapnia as well. And number three, in addition to all of those things, you can have quite a lot of circulating cytokines. And because of that, you do get a systemic inflammatory response. So why is it important, you ask? It's important because it is common. It's one of the commonest things that we see, sometimes as a presenting problem in the ICU, sometimes as a complication of multiple other issues that patients have in the ICU. And it is also important because it is associated with lots of mortality and morbidity. Observational studies, you are talking easily, depending on the severity of the ARDS, mortality of 30 plus to 40 plus %. And then even if you survive ARDS, there are long-term complications to your physical health, long-term complications to your cognition, long-term complications to your psychology as well. So something that it is common, that is brutal, but that can be treated.
Okay, thanks, Dr. Jason. So given that ARDS is an important condition, how do we go about with the diagnosis of ARDS, and when do we even start suspecting that a patient may have ARDS?
Yeah, so the latest classification of ARDS is not very new. It's called the Berlin classification, right? Many years old already. Yeah. And it's being revised at the moment as we speak. But if I just go back to the Berlin classification, you need a few things. First, it should be acute, meaning that this respiratory failure that you see should be within 1 week of the development of symptoms or the onset of a clinical insult. Number two, there needs to be a known cause that can cause ARDS. Number three, when you look at the radiology, for example, chest X-ray, CT scan, there should be bilateral opacities, bilateral infiltrates, bilateral airspace disease. Of course, you should not be diagnosing ARDS if these bilateral infiltrates or opacities are things like collapse of the lung, ocular effusions or nodules, etc. No, it needs to be the airspace disease kind of look. Number 4, it should be not primarily due to heart failure or volume overload, because there's a different thing that requires different management. And number 5, there should be hypoxemia. So if you use the PaO2 divided by FiO2 ratio, you are talking a ratio of less than 300 before you can diagnose ARDS.
Yep.
With a certain amount of positive and expiratory pressure, that's PEEP, either in an invasive or in non-invasive ventilated patient. So a CPAP of 5, an NI non-invasive ventilation with an EPAP of 5, and you have a PF ratio of less than 300. Then you classify the severity based on the degree of hypoxemia. Anything between 200 to 300 is mild ARDS. Anything between 100 and 200 is moderate ARDS. And anything less than 100 is severe ARDS. That is Berlin. As I said, it is currently being revised. And some of the things I can possibly share right now is radiology. I say chest X-ray, CT scans, but increasingly we potentially can use ultrasound to diagnose as well. I talked about heart failure as well as volume overload. It should not be predominant. Yeah, indeed. But we should also recognize that many patients with ARDS also have heart failure. So as long as we think that ARDS is the main condition and not heart failure, that's fine. You can have ARDS. I also talk about hypoxemia. And I think increasingly we will be able to use the SpO2 or the pulse oximetry or the SaO2 or the arterial oxygen saturation over FiO2 ratio as a surrogate for PF ratio, so that we don't need to keep doing the arterial blood gas. And also increasingly we can use high flow nasal oxygen as the minimum amount of PEEP, so that we don't always need to have someone on NIV or intubated before we can diagnose ARDS. In fact, quite possibly in the near future, in low resource settings, which do not have easy access to either NIV or high flow nasal oxygen or even mechanical ventilation, ARDS can be diagnosed without a certain amount of PEEP. So how do we diagnose? Yeah, if we have a patient who comes in with respiratory failure, hypoxemia, acute onset, breathless, you are quite sure this is not predominantly heart failure. You examine the patient, it's got bilateral crackers, you do an X-ray, it's got bilateral infiltrates, very likely this is ARDS.
Okay, thanks, Dr. Jason. So this is a good segue into the next question of the differentials of ARDS. As you had mentioned earlier on regarding issues like fluid overload, and there are also many other conditions that can cause chest X-ray changes and hypoxemia. So practically speaking, what are some of the important differentials that we should evaluate for in the context of someone presenting in such a manner, and practically how do we go about doing so?
Yeah, so I think the first thing is history. We have to be quite sure it's acute, right? I mean, if you take a history and this patient has been having an acute exacerbation of something, that's not really acute, because an acute exacerbation of something means that there's some chronic underlying problem. So things like interstitial lung disease, an acute exacerbation of interstitial lung disease, that's not ARDS. Or patient may have a chronic infection, something like pulmonary tuberculosis. That's not ARDS. Even things like pneumocystis jirovecii or PCP pneumonia in a patient who has got underlying HIV infection and AIDS and has been slowly getting worse over time and then gets acutely worse over the last 1 week, PCP. I would argue that's not ARDS as well. So the history is extremely important. The number 2, the clinical features, the clinical examination is also important. Most of us, based on history as well as clinical examination, can call out the acute decompensated heart failure patients. So these will be patients with underlying maybe poor ejection fraction, or even heart failure with preserved ejection fraction. but they have acute onset of worsening shortness of breath, they have atopnia, you examine them, they have raised jugular venous pressure, they have crackers, they have pedal edema, you do an ECG, you see ECG changes, you do an echo, you see poor ejection fraction. Some of these, yes, they can coexist with ARDS, but if the predominant component are all of the above, maybe you do a CHOP and it's high and you suspect acute coronary syndrome. Yeah, that's not ARDS. So I would say it really depends on the history and the clinical examination, the timing and the clinical features. There are some mimics that are a little bit tricky. Things like diffuse alveolar hemorrhage, for whatever reason, pulmonary renal syndrome or connective tissue disease, associated interstitial lung disease. These are tricky, and sometimes it does take time to manifest itself. And so I would just conclude by saying that we should keep an open mind. There are these differences, things that are more chronic than acute, things that are more hypervolemia than other things, and then things that are tricky mimickers, such as diffuse alveolar hemorrhage.
Okay, thanks, Dr. Jason. So I think next we'll shift gears to look at what are some of the triggers. As you had mentioned at the beginning, that ARDS is a syndrome that arises from an insult that then triggers this whole cascade of events resulting in ARDS. So what are some important conditions that we should evaluate for and think of in a patient coming in with ARDS?
Yeah, we divide this into a direct lung injury and indirect lung injury. So the direct lung injuries ones, the commonest would be pneumonia, be it bacterial or viral, and in this day and age, COVID-19, right? But the direct ones would also include some aspiration of gastric contents, people with swallowing dysfunction, people who just choke on something.
Okay.
The direct ones would also include an inhalational injury. Vaping itself can cause ARDS. The direct ones can also be just a big whack to the chest, pulmonary contusion. That can cause ARDS as well. And then there's the entire indirect list of causes of ARDS. So things like non-pulmonary sepsis, just inflammatory damage from outside the lung that invades into the lungs. So non-pulmonary sepsis from any cause, as long as it's severe enough, it can cause ARDS. Multiple polytrauma, that can cause ARDS as well. Pancreatitis, that can cause ARDS. TRALI, transfusion-related acute lung injury, that can cause ARDS. So multiple different causes of ARDS. And these are just some of the common ones.
Okay, thank you. And finally, to the last question of a patient comes in, there's a high suspicion of ARDS. You've alluded to perhaps looking for some of the underlying etiologies and evaluating the degree of oxygenation failure. So practically speaking, what are some of the initial evaluation and investigations that should be done in a patient, let's say coming into the ICU, and you're evaluating the patient initially for ARDS?
I think the first thing I would do is to do a very quick history and physical. I mean, ARDS is acute, right? So you're not going to be taking long stories. You do a quick history and physical, you check the notes. And the aim of doing that is firstly to see what you're dealing with. Is this ARDS in the first place? Or is this something else like what I mentioned just now? Number two, I would for sure look at the ABCs, the airway, the breathing, the circulation. How much time do I have? Do I need to imminently intubate? Usually it is not that imminent. Usually there's some time. And so when I talk about number two, the ABCs, usually that comprises just giving supplemental oxygen to keep the oxygen somewhere higher than 90 to 92%. So the second part would be the ABC. The third part would be, is there something else that I need to do in a hurry that may not necessarily be related to ARDS? So for example, I mentioned just now that one of the commonest causes of ARDS is pneumonia. That's direct. But there are also very common causes of ARDS. There's indirect, and that's non-pulmonary sepsis.
Yeah.
So the third thing I would consider is, beyond just focusing on the lungs, are there anything else I need to do? If the patient is septic, if the patient is hypotensive, I need to check a lactate. I need to give the antimicrobials. I need to consider fluids, things like that. And so the fourth category of things that I think I would do is then focus on the ARDS. If this is ARDS, I need to know how severe it is. That means that I need to look at either the saturation, the pulse oximetry, or the PaO2 in an arterial blood gas. So a minimum, yes, and ABG to tell me how severe it is. I need to, if not already done, do a chest X-ray to look at how bad, to look at whether it's unilateral or bilateral, etc. And then number 5, the actual treatment. What do I do? I think we can talk about that later on, but it will consist of some form of oxygen support in the first instance, and then thereafter, many other things. So I summarize again. First, we have to do a very quick history and physical. What are we dealing with? Is this ARDS or not? Second, we have to do a very quick ABC. Third, we have to consider non-ARDS issues, such as the treatment of sepsis. Fourth, we have to quickly evaluate the ARDS bits, the arterial blood gas, the chest X-ray. And fifth, we have to treat the ARDS. So I say all this almost as if it's in sequence. In reality, we are doing all of this concurrently.
Got it. Thanks, Dr. Jason. I think that very nicely wraps us up for this first section on the diagnosis and evaluation of ARDS. Thank you, Dr. Jason.
Thanks, Amin. Thanks.